So like everybody else here, I have nothing to disclose. So just very briefly, what is Gavi? So it's a nonprofit organization dedicated to saving children's lives and protecting people's health by increasing equitable use of vaccines in lower income countries. Basically, Gavi operates as an alliance where you have the Gavi Secretariat, which is where I work, which is a coordinating group, but really implementation is done by wide-ranging partners, particularly groups like WHO and UNICEF. So in brief, the Gavi business model. So the idea was to try to improve access to vaccines by pooling demand from the poorest countries and then securing funding to buy vaccines at lower prices from a variety of different donors. And then as a result, increasing access to vaccines. So instead of taking 30 years for vaccines that were first introduced to make it into most low-income countries, to try to reduce that to maybe 5, which is in many cases worked. A key part of that is shaping markets to make sure there's actually enough vaccine available to supply all the countries that are in need of it. And that's a key issue because if you have a finite supply, then you may have to make decisions about where you're going to prioritize using it. But we also realize that because the vaccine actually has to get out of the storage facilities, that the delivery of the vaccines and as well as things like laboratories direct its use are key. The goal also is for Gavi as a group to go out of business eventually, where responsibility for funding these different activities will eventually transition to others, particularly the governments of the countries that are receiving the assistance. So that idea of how does Gavi eventually exit, what's the transition out, is always a big part of our thinking. So just very quickly, this shows Gavi's general growth in terms of fundraising over the last basically roughly 18 years. You can see it increased considerably from 2000 to 2016. A key part of that also has been a rise in co-financing, in other words, the amount of money contributed by recipient countries to paying for the vaccines and other services that they're receiving. So just very briefly in terms of how all of the previous presentations and the background for yellow fever fit into from a Gavi perspective. So as was mentioned, everything that we're doing ties into supporting and implementing the I strategy for eliminating yellow fever epidemics, coordinated by WHO. A key part of Gavi's contribution is the Gavi board has approved $428 million for yellow fever vaccination between 2016 and 2020. Through use of vaccine routine immunization, preventive campaigns, as well as outbreak response campaigns. We know that outbreak responses are a major issue, just from a very narrow Gavi perspective. Responding to the DRC outbreak that resulted from spread of virus from Angola costs $13.7 million alone. So we realize that if we can prevent outbreaks or detect them and end them sooner, that will basically save money for a lot of groups. It'll save a lot of pain and suffering, but it also is in the financial interest of everyone involved as a more efficient way to eliminate yellow fever. So this slide shows a modeling study from the DRC Angola outbreak, basically showing that in Luanda alone, the rapid outbreak response prevented 360 deaths, estimated through this model, which just indicates that a relatively rapid outbreak response does save lives. And it just makes you wonder what would have happened if you have an even more rapid outbreak response than was the case here. And in terms of that narrow efficiency terms, this slide just points out that the spread of the outbreak from Angola to the Democratic Republic of Congo required the use of a considerably larger amount of vaccine than would have been the case in just if the outbreak had only remained in Angola. So if we'd been able to respond early enough and contain the outbreak early enough that it had not spread to DRC, there would have been some obvious savings just only in terms of vaccine that was used. As part of the assessment that Dr. Demenal described, we looked at how long it was taking to confirm cases on average within the high-risk countries in Africa in terms of yellow fever. And we found that if you just look at the samples that were positive at the national level, therefore the samples that need to go to the regional reference laboratory due to the cross-reactivity issues that Drs. Demenal and Koopmans mentioned, it's taking on average 100 days to complete testing on a sample. It can sometimes go faster, particularly if there's a real urgent outbreak concern. It can go as fast as about a month. But if your average is 100 days before you have the information to know if you've had an outbreak or not, that's not good. The maximum was about 18 months. So through the laboratory outreach that was mentioned, as well as some excellent work by our partners at FIND looking at the current outlook for the yellow fever diagnostic market and consultations with a wide range of groups, we identified a number of problems, including a lack of validated diagnostic test kits, frequent stockouts of reagents that preventing testing from happening, limited quality assurance, quality control assessments, as well as limitations in training, sample transportation, and just underlying almost all of it, a lack of funding. So in terms of what can Gavi potentially do about it, so we identified a number of potential solutions for that, including trying to market shape yellow fever diagnostics somewhat similar to the way that Gavi tries to market shape vaccines to make sure that there's enough validated diagnostic test kits that are actually available for the need. That's tricky because the size of this market is very small. It's only about 14,000 samples a year in Africa in 2017, but hopefully by pulling it together we can make some progress. Hopefully we can address some of the bottlenecks in procurement to avoid stockouts, improve the regularity of QA/QC activities as well as training, and address some of those problems of sample transportation and provide adequate funding. So I'm going to focus on the first and the last, the diagnostic test availability and the funding, just very briefly. So as was already mentioned, because you get RNA present in the blood early on in infection and then later on IgM and then IgG antibodies, in order to really be able to determine if someone had yellow fever, you need to be able to look for both the RNA through molecular testing as well as antibodies. But unfortunately at this point there are no diagnostic commercial kits that meet the criteria that we want to see for either molecular tests or serology in terms of quality assurance. In other words, we don't know, with our tests available, we don't know if they work. We're probably a little bit closer with the molecular tests like PCR than we are with serology, but this is definitely a gap that we need to fill. Also, in terms of funding, I mentioned that Gavi tends to try to put itself out of business. So as we are trying to address those funding gaps, we're also from the beginning trying to plan on how are we going to make sure that when Gavi does exit supporting this area that the capacity will be maintained. So we're trying to make sure that we set expectations from the beginning that everyone plan on countries needing to basically include budget line items around this. Although it probably wouldn't be required in initial years as we're working out some of the details. But in general, the transitioning laboratory capacity would be included in the broader scope of Gavi transition planning. So the upshot was that in November, the Gavi board approved actually a total of $13.5 million. The $8.2 million that Dr. Now mentioned was just for procuring laboratory reagents and test kits. But we also secured funding for $5.3 million to address some of the laboratory network issues around technical assistance, quality assurance, quality control testing, and sample transport. And again, this just applies to the countries that are both at high risk for yellow fever and eligible for Gavi support. So just very briefly, in conclusion, this diagnostic initiative is very much focused on yellow fever, but it's also multifaceted. There's a lot of different partner groups that are involved, particularly WHO, the Institut Pasteur Dakar, Centre Pasteur Cameroon, USCDC, Uganda Viral Research Institute, FIND, National Public Health Laboratories who have already been engaged through these assessments, Erasmus Medical Center, and the different independent experts on the eye technical working group. And we hope that this will expand over time as we make progress in addressing some of these issues. It's worth noting that this is very focused on the laboratory issues. We realize that other problems, such as making sure that cases are detected and samples are collected, are out there, and so those will also be addressed, although potentially through other mechanisms. Because of that, we definitely think there's scope for collaboration across silos, if you will, with other initiatives. So, for example, I think the problems with international and domestic sample transportation affect almost anybody working in diagnostics, and I think that's something where the more collaboration is, the better. Also, laboratory quality assurance, we very much hope to build on and take advantage of things like SLIPTA and SLIMTA, which many people in this room have been instrumental in moving forward. So again, very happy to take any questions, probably particularly during the next break, given the limited time, but thank you.